Today I'm going to update you about what we started here in Qatar for heart failure program. Because I just started, like, let's say the program we started like 9 or 10 months ago, and we started with outpatient clinic, and recently also start to see inpatient for heart failure. So starting with the heart failure, let me tell you a few things. That, as you all know, 1 in 8 deaths in the US has a heart failure listed on the list certificate. And as the statistics in the US in 2010, American Heart Association listed the heart failure is one of the leading cause of hospitalization and deaths in US and throughout Europe. And the estimated direct cost in 2010 in the US alone is $39 billion. And this was, like they spend all this money on treating the patient, getting heart failure programs, and the purpose was for these programs is to serve and to meet the growing population of heart failure. And the main goals was to improve the quality of life and improving the treatment management of the patient with heart failure, also reducing number of the hospital admission and empowering the patient to manage their own health. For the outpatient portion, the main thing is, to keep the patient out of hospital as long as possible. And also, if the patient coming to the hospital, to detect the decompensation as early as possible. So treating someone with early decompensation, this will be easier to manage, and also their stay in the hospital will be shorter. So let me tell you how things here in our hospital. So when we look to the inpatient, I look at it before. As I told you once before, for the admission, it was just for 1 month during the January 2012. I looked to the admission was for the CCU and for heart failure. As you can see, we have here 126 admission in 1 month. 16 admission of them was heart failure with ejection fraction less than 35%, which means it's almost, or it is 11% of our admission to CCU in 1 month. Then, when we look to the outpatient clinic, I just reviewed all patients came to the clinic from May 2011 till January 2012, and the total number of these patients was 16,000 visits. 2,003 visits of them was for heart failure and ejection fraction with ejection fraction less than 30%, which again 11% of the patient coming to the heart hospital as outpatient. So when I look at it carefully, I wanted to see the ethnics, like who. So I found that Qatari is 20% coming to the heart failure clinic. 25%, sorry, and Pakistani is 9%, Indian 20%, Bengali 9%, 5% for Filipinos, Arab nationalities, different Arab nationalities 17%, and then different nationalities mean like European and South American is 16%. This is very important data to know which group we are dealing with, or because like each background is different regarding their way of life and the education they need to decrease symptoms of heart failure and to be compliant with their medication. So also I looked to the age, so I found that 58% of those coming to the outpatient clinic is aged between 40 and 59, so it is in the productive age, and only 5% was above 80. Now, then we started a research. We wanted to look to the readmission because it's very important. As our hospital, it's always congested. We send the patient home. A few weeks later, he or she comes back. So we are now doing big research about the readmission, the rate, the causes, everything about readmission. So let me tell you, for heart failure in the last 15 months, we have 560 admission for heart failure and 129 readmission in 3 months, which is 29.3%, which is a little bit higher than the usual, or what we see in North America. It's about between 24 and 27. Here is a little bit higher. So when we look also to readmission itself, so we found that 31% female and 69% male. So, and then the age group was very important. Who got readmitted more to our hospital? So we found that those who are, the age between 60 is 79 patient, which is 44% below 60 and 56% above 60. But those above 60, we get them two groups. Below 80 and above 80, because normally or in the Western world, above 80 it's a big population, and the readmission is higher in this among this age population. But here it's different, totally different. 82% of the readmission, is below 80, and just 18% above 80 years of age. Also, we looked to again the nationalities. We looked at for the admission. We found that 46% are Qataris and 54% are non-Qatari. Despite the fact the admission was 25% for Qataris, but for the readmission is 46 for Qataris and the 54% non-Qataris. So when we look to the highest portion, which is 54, we found that 36 Asian. I mean Asian. It's like including all Filipinos, Indian, Pakistani, everything, 36% of readmission, and 64% of the non-Qataris are Arab nationalities. So this leads to a few things I want to mention later on about the compliance and all these things. So let me tell you, for readmission, for admission heart failure in our hospital, we have the first admission in the last 15 months was 1,206 days of admission for heart failure. But for the readmission, it was 618, so which is 50% of the days are wasted here for readmission. And total is 1,824 days for admission in the heart hospital because of heart failure, which is 4.9 years. It's a lot. So my job here, I think I have to be working on the readmission. Well, I cannot help with the first admission, of course, but the readmission, the heart failure program, the main goal for us to decrease this number at least 10 to 15% next year, hopefully, inshallah. So let me tell you, for the readmission, the main thing, I look at it, on our research, why there is readmission. Patients are non-compliant to fluid restriction. They are not compliant for the salt restriction and medication. But number one is fluid restriction. They don't restrict fluid as we ask them. And when you look at it, it is thirst. So recently this was published 3 months ago on the Heart Failure Journal, the European Heart Failure Journal, and it was done in Sweden. This is a systemic literature review. They reviewed 4,300 patients to see how bad is the thirst for them and how do they feel about it and what is the impact of thirst. And they found that it was described as annoying and cause of suffering for patients when they feel thirst. And most of them couldn't tolerate the thirst, and they couldn't they found 23% cannot tolerate thirst and cannot restrict fluid because of feeling of thirst. So the conclusion for this review was that the thirst may increase and experience of distressing for the patient with heart failure. And we need to look at it regarding medication. Which medication causing this thirst more? Is it diuretics? Is it inhibitor or beta blocker whatsoever? Also, the weather, which for each country is different. So the restriction of fluid must be varying because most of the time they restrict 1.5 liter per 24 hours. But in such hot country in Qatar, we cannot say 1.5 because some people can lose 2 liters of sweat in summertime. So this is very important to have more research to know more. But one of the most important things for non-compliance is thirst. Also, there was other study for the patient adherent to medication. This was done in Denmark. And they looked at the patient with ejection fraction less than 30%. They looked at 8,000 patients over 7 years from the outpatient clinic. They wanted to see whom is more compliant from the heart failure perspective, who is more compliant for medication. So they found they put just 3 medication, the ACE inhibitor, the beta blocker, and the diuretics. And they found that the patients who are following in the specialized heart failure clinic is more compliant. So the first year, they found that they are 93% compliant to the ACE inhibitor, 92% compliant to beta blocker, and 86% is compliant to diuretics, male and spironolactone. And in 3 years, they found 90% compliant to ACE inhibitor, which is decreased a little bit from the first year, but still high. It's 90%, and then 88% to beta blocker, and 47% to diuretics and spironolactone. And when they looked to the patient who were transferred to a general practitioner clinic to follow up for heart failure, they found that in 1 year, not in 3 years, in 1 year, they found that 89% just compliant to ACE inhibitor, and 98% is compliant for beta blocker, and 72% for diuretics, especially spironolactone. So they concluded that the heart failure clinic and heart failure program is doing much better with patients with ejection fraction less than 30% regarding the compliance to medication, regarding to less readmission, and regarding the outcome. So they recommended that if you have the facility and you have the fund to maintain such heart failure programs, is the best outcome. Then what we think, like for us here, what's happening? Why we're getting this readmission? Why we're getting the non-compliance? It's the education. We don't educate the patient and the family enough about the restriction of fluid, salt restriction, activities, which patient can do what, because it's different. It depends on the general condition of the patient and his age. It's very important thing. So now my team and I trying to build up educational process so each patient has to go through it, hoping that with this education we can decrease the readmission. So our referral to the program, most of you know, but let me tell it again, like ejection fraction will get the patient with ejection fraction 30% or less. Refractory, those who are refractory heart failure with not responding to first line of treatment, and also via direct communication, because each patient got his own scenario, so we need direct communication. And this will be the flow for our patient in the clinic. For new patient, they will go for the nurse and then seen by a specialist or fellow. Also, they will be seen with dietitian and social worker for the first time. Then the consultant for physical examination and finalizing the management plan. And then the pharmacist will sit, after we finalize the plan, will sit with the patient to educate them regarding medication. This is from the first visit, and then follow-up will be much easier as long as there is no complication, but if needed, we will see dietitian again, I will see pharmacist again. Now, we have the two main arms for heart failure who help us out. The first most important part is cardiac rehabilitation, which led by Dr. Muhammad Al-Hashmi. And I know it's a great burden because we are sending loads of patients, but it's very important for heart failure patient to have a our cardiac rehabilitation program. And what they are doing, they see each patient, they assess the patient and they tailor what kind of physical exercise the patient can do. And I believe Dr. Hashmi will talk tomorrow about this program in details, inshallah. And the other program here we have is the cardiac electrophysiology from Dr. Nidal. And as I told him many times, you will be swamped from our patient because we start to refer more and more patients for ICD, CRT, those with ejection fraction less than 30. And I think they are very helpful for us. And last thing let me tell you about is the research. So now we are involved in several research. The Inter-CHF, it is international, the Intermax, the readmission, the one I get most of the data about today, it was from this research. The biomarkers was Haitham Abu Salah. He will talk about his research today. And genetic, it will be Despina, and we'll listen to her today as well. So it's a great to know everything about genetics and biomarkers from you both. And let me tell you a quick thing about the Inter-CHF. Inter-CHF is, like as you know, the heart failure, is identified as a global epidemic. But most of the data, or if not all the data, came regarding the management, regarding symptoms, causes, everything about heart failure coming from the Western world. We don't have data or enough data from Africa, Asia, or South America. So the Inter-CHF is international registry to collect, to collect data regarding causes, treatment, barriers to care, and the outcome for heart failure in Africa, Asia, and South America. And it will be a cross-sectional longitudinal registry in 2 phases over 12 months. And these phases will include the qualitative and prospective process, respectively. This study is to understand the etiology, diagnostic, and management. Here it will be for 5,000 patients across the world. For Qatar, we will have 200 patients enrolled over the next year, and we will be using the iData fax system, which is electronic data capture system, which will allow site user to enter the data directly to the international database, and then it will be analyzed at the end. And I believe the main office is McMaster University in Canada, with Dr. Hisham Dikenish. Then I'm not the best to talk about this. I'll leave it to Dr. Kirkling, but we are also trying to get involved with the Intermax. The Intermax is interagency registry for mechanically assisted circulatory support. It is headed by the National Heart, Lung, and Blood Institute, FDA, and the Center for Medicaid Services. It's as you know, LVADs or any circulatory support is not just it's not a simple procedure, and it doesn't it's not for a short time, except for when it's bridge to transplant or bridge to recovery. But as a destination therapy, this will be lifelong commitment, and because we don't have enough hearts to for transplant all over the world. So I believe that the LVADs, becoming more and more destination therapy. So it's lifelong commitment between the patient and the physician or the program. So this is very important and unique program. The Intermax, or now is the IMAX, the best to talk about it is Professor Kirkling, so I will not, I will leave it to him to explain for us the difference between Intermax and IMAX. It's very important for us to know the complication and its follow-up for pre and post implantation, and when the patient to be explanted, or so it's data about everything, about the experience, about the consensus of the circulatory support, and it is great thing. So let me tell you what is the heart failure team here in Heart Hospital, and this is my last slide. Well, that's me, and then Dr. Al-Hashmi, Dr. Batal. This is a sleep consultant for now in the in heart failure, hoping the number increase in the future. Then Dr. Juma and Dr. Wafer, they are the specialist, the cardiologist. And then Stella, our nurse practitioner, and she's doing a lot for this program to keep it running day to day. And then Hajar, she is our head nurse, and also she started with me first day I'm here for heart failure. She's doing great job. And Dr. Haitham, I wish I had his picture. I couldn't, sorry. He's joining us for the biomarkers, and you'll see him a lot here with us in the research arm for the heart failure. And then Bispina, and you will hear from her today. And also she is in the research arm in our group, and she will be talking about genetics. So genetics, so she got the most complicated topic for me, at least. Okay, so thank you for coming. And so thank you so much for allowing me to introduce what's happening here. And if any question, yes. Yes. Okay, we will have the question later on.